Hello doctors, good evening. This is Dr. Hira Salman. So today we are going to start ENT and it's a very short chapter actually. So we will complete in this session inshallah. So starting with the nose and sinus. So first of all sinusitis. A 34-year-old woman present with facial pain, discolored nasal discharge, bad taste in her mouth and fever. On physical examination she has facial tenderness. Which of the following is the most accurate diagnostic test? So you are going to go for which test which is considered to be the most accurate one. This is a case of sinusitis, so we'll go for the sinus biopsy or aspirate. So sinus biopsy or aspirate is considered to be the most accurate diagnostic test for sinusitis. Now remember that in infectious diseases the radiology test is never the most accurate test. Only a biopsy or aspirate can give you a precise microbiological diagnosis. There is a difference between a question that says what is the most accurate test and one that asks what will you do. CT scan is the most common wrong answer to this question. We will never go for the CT scan. You cannot stain or culture a CT scan definitely. So we will not go for that. For the diagnostic testing, if the question describes typical symptom of sinusitis such as face pain is there, discolored nasal discharge is there, fever, then you have to answer start antibiotics, for example amoxicillin and a decongestant. So always remember, if they're asking you for the management option and the typical symptoms are there like face pain, discolored nasal discharge, fever, so we'll definitely start antibiotic. No radiological testing is needed. If the question asks what is the first diagnostic test, then of course the answer is CT of the sinuses, not an X-ray. If they really want you to answer CT, they will give you definitely this clue that this is the first diagnostic test. What is the first diagnostic test? The first diagnostic test will be the CT, not an X-ray here, especially in case of sinusitis. X-ray does not have enough sensitivity or specificity to be the first test, right? Now, use of sinus biopsy, aspirate or endoscopy. A biopsy in sinusitis is needed only if infection frequently recurs. We'll only go for the option of biopsy if the patient is complaining of recurrent infections and there is no response to different empiric therapies. You have already applied for so much therapies, but the patient is not responding, and only in that case we will go for biopsy. Tip here for assess culture of nasal discharge is always the wrong answer for sinusitis. We'll never go for the culture, especially in the case of sinusitis, right? We'll never go for the culture. It's always better to start antibiotic, but if you see that we have to go for the diagnostic testing, then we'll go for the CT, right? Or the most accurate one is of course that's a biopsy and aspirate. Now here you can see the sinusitis. Now, a 34-year-old woman present with facial pain, a discolored nasal discharge, bad taste in her mouth, and fever. On physical examination, she has facial tenderness. What is the most appropriate next step or action in the management? Now, they're asking you the most appropriate next step. They're not asking you the most accurate test, right? So, here we will give antibiotic. That is considered to be the most accurate management. Or, sorry, the most appropriate next step in management. So, that is allowing the use of antibiotic, that's amoxicillin, clavulanic acid, that's a combination, that's augmentin and decongestant. So when the diagnosis is clear, as in this case, radiologic testing is unnecessary. Never go for CT, right? Amoxicillin, clavulanic acid or doxycycline and trimethoprim, sulfamethoxazole remain first line therapy for both otitis and sinusitis. If it's a case of sinusitis or if it's a case of otitis, we'll go for this therapy. The efficacy of these agents is the same as newer or more broad spectrum agents such as quinolones. Imaging is done if the diagnosis is equivocal. Only you will go for the imaging when there is equivocal diagnosis. A decongestant is used in all cases to promote sinus drainage. If we want to, promote the sinus drainage, then only we can use decongestant. Erythromycin is inadequate because of poor coverage for streptococcus pneumonia. There is not a good coverage option. This erythromycin is not a good coverage option for streptococcus pneumonia. Then linezolid, although excellent for resistant gram-positive organism, would not cover hemophilus, right? If we want to give linezolid, but that is not going to cover hemophilus. Antibiotics are really needed because most cases are viral in etiology and antibiotics are used with fever and discolored nasal discharge. Those who are really having fever with discolored nasal discharge, so they are only prescribed with the medicine, and that's a combination of this amoxicillin and clavulanic acid. But most of the time, if it's viral, then we don't need any treatment. Now we're coming towards cavernous sinus thrombosis. The cavernous sinus is a venous drainage system that receives venous drainage from the face, nose, orbits, and tonsils. So from all of these structures, we're going to, receive the venous blood. That's venous drainage. The cavernous sinus is adjacent to the sphenoid sinus. It's a position of cavernous sinus that it's actually adjacent to the sphenoid sinus, allowing sinusitis to thrombose the cavernous venous sinuses, right? So allowing sinusitis to thrombose because of its position, right? Now patient has fever, headache, ptosis and proptosis. These are all the features in a patient. Symptoms arise from damage of cranial nerve 3, 4 and 6. Trochlear, this oculomotor, trochlear and abducens, right? All the cranial related to the eye, which travel through the cavernous sinus. And the key to the most likely diagnosis question is a history of sinusitis and diplopia with inability to move the eyes normally. So if in a vignette, if in a question, if you see there's a history of sinusitis and there's diplopia and there's an inability to move the eyes normally, so this is most likely the case of cavernous sinus thrombosis. There you can see it's a sphenoid sinus here. It's a cavernous sinus. It's internal carotid artery. This is oculomotor nerve. That is third, fourth trochlear, and fifth has three division. One is ophthalmic, one is maxillary, and third is mandibular. Third is not mentioned here, but ophthalmic, maxillary, and third one is mandibular, which is not here actually anatomically. And this is abducens nerve, which is the sixth cranial nerve, right? Now the best initial. So here you can see this is cavernous sinus. Now, the best initial test is CT or MRI with contrast showing the thrombosis. So, most important in case of this cavernous sinus thrombosis, we'll see the thrombus, right? So, we'll go for the CT or MRI. Both of them are considered to be best initial one. There is nothing significant like we'll go only for the CT or only go for the MRI, whichever you want to go ahead, because both of them are considered to be best initial testing. In most patients, lumbar puncture shows CSF with neutrophils. The infectious organism are Staphylococcus, Streptococcus, and anaerobes. You have to treat your patient with vancomycin and ceftriaxone, broad spectrum covering the MRSA also, and possibly anaerobic antimicrobials. Ampicillin sulbactam with vancomycin is a good choice, right? So we can give this combination. And steroids decreases inflammation. Anticoagulation is controversial, so better not to go for the controversial option. It's always better to choose clear-cut cancer, and here it's antibiotic, right? That is vancomycin and ceftriaxone possibly anaerobic antimicrobials. You have to treat them, those especially with these antibiotics. Then we have this Tolosa-Hunt syndrome. This is a granulomatous inflammation of the cavernous sinus with ophthalmoplegia. So whenever there is ophthalmoplegia with granulomatous inflammation of this cavernous sinus, this term is known as Tolosa-Hunt syndrome. Look for eye pain and paralysis of the same cranial nerve, that is third, fourth and sixth, that are involved in cavernous sinus thrombosis. Same cranial nerves are involved here, and the patient must be presenting with eye pain and paralysis of these nerves. You have to diagnose your patient with MRI, and you have to treat your patient with steroids, right? So it's just inflammation of cavernous sinus and associated with ophthalmoplegia. And same nerves are involved, third, fourth and sixth, like oculomotor, trochlear and abducens nerve. Then we have this epistaxis. Epistaxis is 90 to 95% anterior venous bleeds of the Kessel-Batch venous plexus. We are going to see here, and have patient blow the nose and hold it closed for 5 minutes. More severe cases need vasoconstrictor drops. We can go for the vasoconstrictor drops option, so the nitrate option, or the sealant, the glue, and occasional nasal packing can also be done. You have to give phenylephrine or oxymetazoline to these patients in order to stop the blood, right? So we just memorize this phenylephrine or oxymetazoline are option, pharmacological option. 5% bleed are actually from the posterior side, right? So 5% are posterior and arterial bleeds, and these are very dangerous and need packing or ballooning. So must remember, because this is very important for our exam point of view, that we need packing and we need ballooning, especially in the case of posterior nasal bleed. After packing, give cephalexin to prevent growth of staphylococcus and toxic shock. Of course, after packing, we have to give antibiotic cover, right? So we'll give this antibiotic cover, especially against staphylococcus and toxic shock, and the antibiotic will be cephalexin. Check platelet count if bleeding persists or recurs frequently, right? If patients bleed a lot frequently, then you will go for the platelet count testing. That's important. Now we're coming towards the ear. The ear, first we're having this otitis media. Otitis media presents with redness, immobility, bulging, and a decreased light reflex of the tympanic membrane. So especially in case of otitis media, you will see the involvement of tympanic membrane that will be immobile, red and bulging. Pain is common. Decreased hearing and fever also occur. So the hearing impairment, fever, and this all immobility, bulging and redness of the tympanic membrane, if it's there, then of course you have to choose otitis media. Which of the following is the most sensitive physical finding for otitis media? For otitis media, the most important finding is the tympanic membrane immobility. Immobility is so sensitive a physical finding that a fully mobile tympanic membrane essentially excludes otitis media. If you see a patient whose this tympanic membrane is fully mobile, you will never say this is a case of otitis media. Alright? Then we have tip, that is radiological test for otitis, always the wrong answer. For the diagnostic test and treatment, tympanocentesis for a sample of fluid for culture is the most accurate diagnostic test. We have to choose tympanocentesis if there are multiple recurrences or if there is no response to multiple antibiotic. If there is no response to multiple antibiotic, only in that case we will choose this tympanocentesis. Other than that, tympanocentesis for a sample of fluid culture is the most accurate diagnostic test, but only in the case when multiple recurrences are there. Now, or if there is no response to multiple antibiotic as well. Amoxicillin is the best initial therapy. If there is no response or the patient is described as having been recently treated with amoxicillin, then the answer is, then go for the combination. You can go for the amoxicillin clavulanate combination. You will go for the azithromycin or clarithromycin combination, ceftriaxone and loracarbev combination, levofloxacin, gemifloxacin, moxifloxacin, all of them you can try, but it's always better to try first amoxicillin first. But if your patient is not responding with amoxicillin, then only you will move towards these medications. But see, quinolones are relatively contraindicated in children. They are contraindicated in children. You must remember this point is very important as far as the adverse effects are concerned. Then we have this otitis externa. This is a cellulitis of the skin of the external auditory canal, also known as swimmer's ear. So swimmer's ear, you have to think always that whenever it's written swimmer's ear, it means that this is a case of otitis externa. Exposure to water raises the pH of the canal, facilitating bacterial growth. Maceration of the canal with cotton swabs also promote bacterial growth, and there is pain on moving the tragus. So whenever the patient is experiencing, the word is very important in veneers, right? So if the pain is there on moving the tragus, it means that this is a case of otitis externa. If there is immobile tympanic membrane, you're going to see an examination that is a case of otitis media. Here, culture of the yellow-white discharge is not helpful as all ear canals will grow staphylococcus or this propionibacterium acnes and pseudomonas. Now, you have to treat with topical neomycin or polymyxin, topical quinolones you can give, or gentamicin. Use hydrocortisone ear drops to decrease inflammation and relieve pain. Removing desquamated skin and sediment will make it easier to disinfect the ear canal, right? So removing desquamated skin and sediment will make it easier to disinfect the ear canal. That we can do. Now, acetic acid or vinegar inhibits bacterial growth in the ear canal. That is an important point to ponder here, that acetic acid, that is vinegar, can inhibit bacterial growth in the ear canal. Okay. Now, malignant necrotizing external otitis, that's although the name sounds similar to otitis externa, but this infection is actually cranial osteomyelitis. So the word malignant necrotizing external otitis is actually cranial osteomyelitis in the portion of the skull near the auditory canal caused by Pseudomonas. So Pseudomonas is the one which is commonly involved here. It occurs in poorly controlled diabetic patient. Always remember, whenever there is a case of diabetes, you always consider pseudomonal infection in that patient. Severe ear pain is common. Malignant external otitis can be rapidly fatal as the pseudomonas aggressively invade the base of the skull of the elderly, immunocompromised patient, and spread. So that's also important. Malignant external otitis can be rapidly fatal as the pseudomonas aggressively invade the base of the skull, right? If they are going to involve the base of the skull, definitely they are going to be very fatal. And immunocompromised patients especially, it's spread very fast. Now, the best initial test is CT or MRI. You can go for any of these options. The most accurate test is biopsy. You have to treat your patient with IV antibiotics that are effective against pseudomonas, such as the ceftazidime or cefepime or quinolones or estronam, or the anti-pseudomonal penicillins, for example, combination of piperacillin and tazobactam. If the question asks you to choose a single agent, then you will always choose quinolones, that is ciprofloxacin. Point to ponder here is topical antibiotics are useless in malignant external otitis. So we are usually not giving topical antibiotics in these patients. Now we're coming towards mastoiditis. Mastoiditis, this is an infection of the mastoid ear cells that occurs when nearby otitis media spreads. So when nearby otitis media spreads, then only you're going to see the infection of these mastoid ear cells. The skin over the mastoid process can become red and the area tender. Inadequate or delayed treatment can result in deafness and meningitis. Of course, if you just delay the treatment, the patient can go into deafness and there may be meningitis. The organisms are the same with pneumococcus, Haemophilus and Moraxella. So these organisms, these are responsible for creating this mastoiditis. Which organism? This pneumococcus, Haemophilus, Moraxella. So these pneumococcus, Haemophilus, Moraxella, they are responsible for actually causing this disease, that is mastoiditis. Best initial test is CT or MRI. You can go for any of one of these tests. If there is no response, the most accurate test is a biopsy. Always consider CT MRI first. If there is no response, most accurate is biopsy. You have to treat your patient with ceftriaxone or levofloxacin. That's quinolones. Surgical debridement is sometimes needed, but recurrent or chronic infection is treated like osteomyelitis. Biopsy and use vancomycin combined with piperacillin or tazobactam. So you can give this combination also. That is piperacillin tazobactam combination with the use of vancomycin, right? Then we have this cerumen impaction. Cerumen impaction impacted earwax, causing hearing loss, earache, and ear fullness, tinnitus, dizziness. So when the cerumen impacted, it can cause all of these things like hearing loss, earache, ear fullness, tinnitus, dizziness. You have to diagnose cerumen impaction with otoscopy. You have to go for the otoscopy. Remove earwax when symptomatic. Melt it out with cerebral lytics such as hydrogen peroxide. First you need to give hydrogen peroxide, right? Or mineral or liquid glucosate, right? And then after giving cerebral lytics, then you can remove it. Alternative is jet irrigation, that is high pressure water, you can just apply and remove it. But the cerebral lytics or irrigation manual remover are all equally effective. So whatever option you want to go for, cerebral lytics or this jet irrigation or just manual removal, that you can all do in case of cerumen impaction. Then we have this nystagmus and vertigo. The feeling of the room is spinning around you is vertigo. Spinning around you. And that's a feeling, and that is actually vertigo. Any cause of vertigo can produce the jerky eye movements known as nystagmus. Any cause of nystagmus and vertigo can also lead to nausea and vomiting. The distinguishing factor among the cause of vertigo is the presence or absence of hearing loss and tinnitus. So see, the distinguishing factor among the causes of vertigo is the presence or absence of hearing loss and tinnitus. So that is actually, this is a distinguishing factor, right? That's nystagmus and vertigo. Now, central nervous system causes of vertigo. Central nervous system causes of vertigo and nystagmus are not associated with hearing loss and tinnitus. So see, CNS causes of vertigo, they are not associated with hearing loss and they are not associated with tinnitus. It is easy for a stroke to damage speech but not hearing, right? So hearing is actually not impaired in that case. Stroke of the posterior circulation of the brain, that is the vertebral or basilar system, is not associated with hearing loss or tinnitus. So these associations are not there. Hearing loss is not there, tinnitus is not there. Neither is a multiple sclerosis, but you need a brain MRI for both. Another cause of vertigo and nystagmus that does not cause hearing problem is phenytoin toxicity. So that's another cause of vertigo and nystagmus that does not cause hearing problem. That is actually phenytoin toxicity. Phenytoin toxicity, there is no hearing loss, but there is vertigo and there is nystagmus. Now we're coming towards peripheral inner ear causes of vertigo. So what are the peripheral or inner ear causes of vertigo? Both labyrinthitis and Meniere's disease cause vertigo and nystagmus in association with hearing loss and tinnitus. So if it's a case of labyrinthitis, if it's a case of Meniere's disease, both of them can cause vertigo. And nystagmus in association with hearing loss and tinnitus. Now, labyrinthitis is acute and Meniere's disease is chronic and recurrent one, right? So, labyrinthitis, we must memorize that this labyrinthitis is acute actually and Meniere's disease is chronic and recurrent. If there is acute hearing loss, a glucocorticoid should be used. So, whenever there is acute loss, we'll go for the glucocorticoid option. Mania is treated with diuretics and carbonic anhydrase inhibitors if the pain or hearing loss and vertigo are debilitating and chronic ablation of the inner ear on the affected side is performed. Maclizine may help, right? So this is the condition. If the pain or hearing loss and vertigo are debilitating and chronic, then we can go for the ablation of the inner ear. Which one? On the affected side, right? Is performed. The ablation is performed on the affected side if there is, debilitating or vertigo associated with hearing loss and all that. Maclizine may also help. Now, in addition to hearing loss, tinnitus, patient with aqueous neuroma, that is a cranial nerve tumor, could have ataxia. So it's not like that. In addition to hearing loss or tinnitus, if patient is also having aqueous neuroma, that is a cranial nerve tumor, so those patients could have ataxia also. Now, a CT MRI specifically looking at the internal auditory canal localizes the lesion which must be surgically removed, right? So, if you have seen in CT MRI that there is something specifically is mentioned here, or there's some abnormality you are going to find there, then definitely you have to surgically remove that thing. Now, in perilimb fistula, a history of barotrauma or exposure to explosion is critical to the diagnosis. If it's case of perilimb fistula, definitely barotrauma history or exposure to explosion must be there. The leakage hole in the oval window of the inner ear can only be fixed surgically. Then only we can go for the surgical option. In BPV, that is benign positional vertigo, there is no hearing loss or tinnitus or ataxia, nothing like that. But this is transient problem in the vestibular semicircular canal system of the inner ear. So actually here the problem is related to vestibular and semicircular canal system. Repositioning the head suddenly can correct the problem. Nearly all resolve in few hours. So there is no effective medical therapy for benign positional vertigo. The only effective therapy is repositioning maneuvers, such as you will go for the Apley maneuver, or we'll see the thing list here, which summarizes the types of vertigo and their management. So there are some etiologies. We'll see the etiology of central or labyrinthitis or Meniere's disease, or this benign positional vertigo, and this perilimb fistula, which is unfortunately, we won't be able to see the whole picture here. But it's okay. What's the etiology of this, right? What's the etiology of central vertigo? Or what's the etiology of this labyrinthitis? And what's the etiology of this Meniere's disease, right? So if it's central one, mostly because of stroke, we'll see. In case of labyrinthitis, viral is the one which is responsible. Meniere's disease, we don't know. BP, we don't know. And perilimb fistula, maybe because of barotrauma, right? Central also because of MS also, right? Multiple sclerosis can also lead to hearing loss. Now, unique features. What are the unique features in case of central one? There must be focal neurological findings, no hearing loss or tinnitus. But see, especially in the case of central if we are considering the cause of okay, so we are considering this causes of vertigo. Central nervous system causes of vertigo. So in case of central nervous system, we are not concerned here about the hearing loss. Actually, we are concerned here about the vertigo. So in case of vertigo, for the central point of view, there is focal neurological findings we can see, but no hearing loss or tinnitus. In case of labyrinthitis, if it's a cause of vertigo, we'll see here there is hearing loss or tinnitus or acute one. Presentation is acute, and we'll see the hearing loss and we'll see the tinnitus. In case of Meniere's disease, the etiology we don't know, and the features also include same as labyrinthitis, but chronic one. Means hearing loss is there, tinnitus is there, but this is not an acute condition. It will take more than 2 weeks, so that is a chronic one. In BPV, no hearing loss, no tinnitus, right? They are the unique features. In perilimb fistula, there is actually histological. We'll go for the histological evaluation, right, or exploration. We don't know exact the word here, but we can just assume that they all maybe because of or history or whatever we will find in the in patient on the physical examination. Now for the diagnostic testing, MRI. In the case of this central cause of vertigo and labyrinthitis, there's nothing specific. For this Meniere's disease, there's nothing specific. But for the BPV, there's worsen with head position. And of course, in perilimb fistula, there is surgical exploration maybe. All right. Then we have this. We already have covered this here, right? Exposure to explosion, the leaking hole, so that will be fixed surgically. So only the surgical option is here in the case of perilimb fistula. Now for the treatment option, Underlying cause we have to treat in case of central one. We can give steroids and maclizine in case of labyrinthitis. We can do sodium restriction and advice for the diuretics one, right? The use of diuretic and sodium restriction for the Meniere's disease. This usually is asked in the exam, right? And head repositioning and apnea maneuver, especially in the case of BPV, and surgical closure of oval window, especially in the case of, yes, perilymph fistula. Now we are coming towards throat and neck. Throat and neck, first we are going to deal with pharyngitis. Pharyngitis, most common one, patient with pain on swallowing. There are enlarged lymph node in the neck, exudate in the pharynx, associated with fever. There is no cough, there is no hoarseness, right? When these features are present, the likelihood of streptococcal pharyngitis exceeds 90%. 90% of strap is involved, sorry. Now for the diagnostic testing, the best initial test is the rapid strap test that you can do in OPD also, right? So this is an office clinic based testing that determines within minutes whether a patient has group A beta hemolytic streptococci or not. A negative test is not always sufficiently sensitive to exclude disease. When all the criteria suggesting infection are present, antibiotics are needed until culture is back, right? If strong evidence of infection is there, definitely we have to advise empirical antibiotic. Now, positive rapid strap test, it means that positive pharyngeal culture. Now, small vesicles or ulcer, if it's there, it's a case of herpes simplex virus or herpingina. If there is membranous exudates, then you should always consider diphtheria, Vincent angina, or upstream bowel virus infection, right? So, upstream bowel virus infection, Vincent angina, this diphtheria, if there is membranous exudate, we are going to see on pharyngeal cultures. Now for the treatment part, penicillin or amoxicillin is the best initial therapy. We'll go for this. Penicillin allergic patients are treated with cephalexin if the reaction is only a rash. If the reaction is only a rash, then only you can use this in case of allergic reaction, right? Are treated with cephalexin. That you can give cephalexin. Because how we can say the patient is penicillin allergic? Because the patient must be presenting with a rash. If the allergy is anaphylaxis, then we can't use cephalexin. Then we have to use any non-beta-lactam antibiotic, that is clindamycin or macrolide. So if the patient is only allergic, means he's going only rashes, he's going to show only rash, then treat him with another beta-lactam like this one, like the cephalexin. But if the patient is showing anaphylaxis, it means that you can't use any other beta-lactam also. You have to always go for non-beta-lactam, that is clindamycin or macrolide. Now, streptococcal pharyngitis is treated to prevent rheumatic fever. So, this is the only point of order here. We have to treat this infection in order to prevent a patient from getting rheumatic fever. There are many choices of antibiotic for pharyngitis. You cannot be asked to choose between clarithromycin, erythromycin, or erythromycin. Of course, erythromycin only different, having more adverse effects such as nausea, vomiting, and diarrhea. So, you're not going to be tested on this point that you have to choose from any one of the antibiotic which is already we can use in a patient. So of course you can choose in between beta-lactam and non-beta-lactam, but not in the categories of beta-lactam. Now for Lemierre syndrome, that is septic thrombophlebitis. This Lemierre syndrome occurs when an infection of Fusobacterium necrophorum, that is from pharyngitis, or maybe because of peritonsillar abscess, or maybe because of mastitis or parotitis, expands beyond the mouth, right? It's going to expand beyond the mouth. Beyond the mouth to infect the neurovascular bundle around the jugular vein. And this around the jugular vein, right? And expand beyond the mouth to infect the neurovascular bundle. Which bundle? Neurovascular bundle. This allows easy spread of bacteria both locally and to the bloodstream. Untreated sepsis causes more than 90% of mortality. If it's untreated one, it can cause mortality which is high, of course. You have to diagnose with CT of the neck, treat with ampicillin-sulbactam combination or piperacillin-tazobactam combination combined with beta-lactam or non-beta-lactam, combined with beta-lactam or beta-lactamase inhibitor. Same antibiotic, same anaerobic coverages, metronidazole or clindamycin. Antibiotics should make surgery unnecessary, right? Antibiotics should make surgery unnecessary. So you have to diagnose with the help of CT. Always give combinations of antibiotics, especially beta-lactam and beta-lactamase inhibitor. Now we're coming towards Ludwig angina. This is the cellulitis of the floor of the mouth. Floor of the mouth cellulitis. We can say this is Ludwig angina. It is caused by the spread of oral flora from dental infection of the mandibular molars into the submandibular and sublingual spaces. So because of the dental infection, we'll see this spread of oral flora is there. especially from mandibular molars into the submandibular and sublingual spaces. The infection will transmit, and because Ludwig angina causes the tongue to swell, it can compromise the airway, necessitating intubation or tracheostomy. So if the airway is compromised, we can go for the necessitating intubation, we can go for the tracheostomy as well. The best initial test is CT of the neck. Treat like Lemierre syndrome with ampicillin surfactant combination and the piperacillin surfactant combination, or combined with the beta-lactamase inhibitor. Any beta-lactamase inhibitor combination you can use in these patients. Just you have to treat this patient like a Lemierre disease. Now we're coming towards salivary gland disorders like sialolithiasis and sialadenitis. Sialolithiasis, these are stones, these are calculi in the ducts draining the salivary glands that cause postparental pain and local swelling. So because of these calculi, because of these stones, there are postparental pain and swelling is there. Recurrent stones lead to strictures and then sialadenitis. So later on, because of these recurrent stones, they can cause strictures, they can cause sialadenitis. Now for the treatment option, stones can be palpated and removed manually. Either you can remove it manually or by incising the distal duct. Both options you have. Stones can also be removed with sialoendoscopy. That you can go for the endoscopy, sialoendoscopy, and you can remove the stones, or with the help of this lithotripsy, you can break the stones, and all surgery directly, right? Now for the sialadenitis, this is an acute bacterial infection of the parotid or submandibular gland, most often caused by Staphylococcus aureus. That's a very important point for exam, right? It's caused by Staphylococcus aureus infection. Eating meals causes swelling and increased pain in the erythematous duct. Of course, eating meals that's actually responsible, and we have to eat, right? So eating meal causes swelling and increasing pain in the erythematous duct. Often pus can be expressed from the duct as well. You have to diagnose clinically because bacterial infection is there. Ultrasound or CT can also help, but most of the time you can diagnose via clinical examination. You have to manage your patient with antibiotic. You go for the warm compresses, you will massage and soak candy to increase the salivary flow. Increase the salivary flow, there will be flushing of the infection, right? Alright, so this end of this ENT session. So inshallah next session we are going to start pediatrics. Thank you so much.